It moves to the colon where it adheres to the host cells, and that causes dysentery. Okay? So the dysentery is essentially the voiding of all the water in the intestines. So there is pretty much no water being reabsorbed from the colon. And this organism, once attached to the host cells, can cause damage to the host cells, and so sometimes you get a bloody diarrhea as a result of that. The cyst is protected from chlorinated water even. So even if you treat the water, sometimes that has no effect on killing the cyst. And in some situations, the cyst can enter the hepatic portal vein and penetrate the liver. Okay? And so if it penetrates the liver, then this can cause liver damage, which can lead to death. So you get two ways of serious disease here: the dysentery, due to the water loss, the dehydration, or the portal entry and liver damage. Any questions about this one? Giardiasis is similar, but this organism, Giardia lamblia, affects the small intestine. Okay? So Giardia lamblia is the cause of giardiasis, and it's the main cause of traveler's diarrhea and most commonly diagnosed intestinal parasite in the U.S. And it's the single most common cause of waterborne diarrhea in the U.S. So if you're out hiking, camping, out in the woods, and you see a nice stream and you get a drink from it, it's probably got Giardia lamblia in it, and you're drinking it. So that's why that's the source of most of the U.S. infections. Okay. Essentially, the life cycle and the infection cycle is very similar to amoebiasis. Here, the cyst is actually infectious, which I'm not going to get into, but the cyst can actually cause the infection before it develops into an organism. The difference between this and amoebiasis is really the site of the infection. Here it's the small intestine. Amoebiasis is the large intestine. Which one do you think is going to give you the more profound diarrhea? Amoebiasis will give you the more diarrhea because it's the colon's sole job to reabsorb water. And if the colon is infected with amoebiasis, it cannot reabsorb water. In this case, it's the small intestine, so the colon is working to reabsorb some of that water. Trichomoniasis is caused by Trichomonas vaginalis. It's a venereal disease or sexually transmitted disease. Most commonly infects the vagina, the urethra, and the prostate in males and females, respectively, of course. This organism may be latent in males, so they may have the organism in their urethras or within the penis, within the deeper urinary tract like the prostate, but never have a symptom. And then it can be transferred to males by sexual contact. And it can cause burning, soreness, discharge, and itching. This is not a life-threatening disease, but it is discomforting, right? So sexually transmitted and causes pelvic discomfort, itching, and burning. All right, just moving on here, and again, I'm going to cover the first 4 or 5 diseases here, and then we'll talk about the drugs. Toxoplasmosis is caused by Toxoplasma gondii, and this organism is actually a bit of a problem in the United States, and we'll talk about why. Felines are the natural hosts, so cats, right? Cats are the natural hosts, and there's 4 common routes of infection. Ingestion of undercooked meat containing cysts. Here in the United States, we don't eat cats, typically. Most of us don't eat cats. So this is not bolded. Okay? Ingestion of vegetables containing the cyst that comes from the soil. So the vegetables grow in the soil. A cat defecates on the soil. The cyst is deposited onto that soil, and then we eat the vegetables that were not properly washed. Again, we wash our vegetables pretty well here. Okay? So not bolded. However, in bold is direct oral contact with feline feces. Okay? And no one eats feline feces knowingly, but the main route of transmission of Toxoplasma gondii is cat litters. Okay? Cat litters. And we'll talk about that in a minute. Also, transplacental fetal infection, so from an infected mother to the baby. This will occur if the mother has an infection and she's pregnant. The organism will cross the placenta and get into the baby and infect the baby. And this causes an eye disease that can lead to blindness that won't be known for 12 or 15 years. So that baby will grow up normally, and after it turns 12 to 15 years of age, it will start losing its eyesight due to having toxoplasmosis in utero. The main concern in the U.S. is in AIDS patients. AIDS-related toxoplasmic encephalitis is a major cause of death. Okay, so this is going to be a main opportunistic infection in AIDS. So, in the immunocompetent, it causes symptoms in about 10 to 20% of patients. And the main route of infection in immunocompetent as well as immunocompromised patients is through changing of the cat litter. And so anyone who's ever been pregnant or has ever had a kid has been told, don't change your cat litter if you're pregnant because of the risk of getting toxoplasmosis and then the risk of passing it on to the baby. Okay? So women who are pregnant should not change the cat litter for that reason. They should not eat cats, lions, tigers, things like that. Essentially, what happens is that the cat will take up the organism, and it is the host for the organism, so it serves as a reservoir. The organism will infect the cat, it reproduces in the cat, and then the cat defecates the organism through the feces, and then we essentially can breathe the dust that contains the cyst of the organism in when changing the litter box. Okay? So you may not know that there's dust in that litter box, but there is, and so when you open it up and dump it out, I don't do this because I despise cats, no offense to any cat people out there. You dump it out, all that dust will contain the cyst. Now, of course, this is not a big deal if you have an indoor cat. Okay, it can be transmitted if the cats don't go outside, so they can pick it up. But really, this is a concern for those cats that are out there eating animals that have the cyst in them as well. Okay, so if the cat's out there, comes running home with a mouse in its mouth, it may have a higher probability of having toxoplasma. Okay? Does that make sense? All right, I want to back up a little bit, talk about its role in schizophrenia. There's very good evidence out there, and I think this is really interesting. There's very good evidence, independent pieces of evidence, that suggest that toxoplasma infections have a role in causing schizophrenia and paranoia. And I'll go through 4 of those with you. So acute toxoplasma infections sometimes lead to psychotic events, not unlike what we see with schizophrenic patients. So acute toxoplasmosis can sometimes cause psychosis. Everyone got that? The second piece of evidence is some antipsychotic drugs, like haloperidol, stop the growth of toxoplasmosis in culture. So antipsychotic drugs like haloperidol stop the growth of the organism in cell culture. You with me? Okay. Many studies have found significantly higher levels of antibodies to toxoplasma in schizophrenic patients compared to the general population. So schizophrenic patients have a higher antibody titer against the organism than the general population does. And finally, the organism causes damage to astrocytes in the brain, and such damage is also seen in schizophrenic patients. So damage to astrocytes, and that type of damage is also seen in schizophrenic patients. So I'm not suggesting, and the literature doesn't suggest that this organism is the cause of schizophrenia, but there's a correlation between this infection and some psychosis. Any question about toxoplasmosis? Any questions about cats? People always have questions about cats because there's a lot of cat people out there. No? Caroline, you're not a cat person? My kids so badly want a cat. And I'm allergic, so I can't have a cat anyway. All it takes is for me to be around a cat for 5 minutes and I'll start sneezing and turn red. No can do. We got a fish. Works. I suggested a pet rock, but it didn't go well. Yeah, at least the fish moves. All right, any questions about toxoplasmosis? All right, so let's talk about the drugs that are used to treat these 4 or 5, however many we talked about. Pretty much amoebiasis, giardiasis, trichomoniasis, toxoplasmosis are covered by metronidazole. Okay? Metronidazole is going to be the drug of choice for Trichomonas vaginalis, Entamoeba histolytica, Giardia lamblia, as well as C. diff. Okay? So typically a drug of choice for treatment of C. diff. Now, metronidazole also covers toxoplasma, as you can see. It will be useful, but sulfa drugs and trimethoprim also cover toxoplasma. So this is something that we're adding to the coverage. Okay? Metronidazole is also good in combination treatment of H. pylori, as well as all anaerobic cocci and bacilli, notably Bacteroides. Okay? So kind of a weird spectrum for this. Very good at anaerobes. H. pylori, C. diff are the bacteria. And then these strange parasitic organisms. So there's no rhyme or reason why this molecule has this kind of weird spectrum of parasites plus bacteria. It just does. Okay? DOC meaning drug of choice. Questions? Okay. Metronidazole is going to be, as far as its mechanism goes, metabolized by the organism themselves. So it's metabolized by the sensitive species. Again, anaerobes will take it in, as far as the bacteria go. Anaerobes will take it in, metabolize the drug into something. And that active metabolite is thought to be a hydroxyamine plus ROS plus RNS. You guys know what this is? Reactive oxygen species and reactive nitrogen species. Okay? Reactive oxygen species and reactive nitrogen species. So this is what I'm showing you here, metronidazole. You see the nitro group over here will be oxidized, giving you this hydroxyarylamine. And then this big circle denotes the ROS and the RNS. Okay, these are radicals. And I show you that on this slide here. So the aryl nitro is going to be oxidized in the presence of oxygen. And that forms, first of all, this species. This is a superoxide molecule. And it is highly reactive. It's superoxide. We talked about this in nervous system, if you recall, with monoamine oxidase inhibitors. There's Dr. Pollack driving away. Monoamine oxidase inhibitors. And superoxide itself is then converted to this organism, or this species. What is this? H2O2, hydrogen peroxide, which is again an oxidative species. And hydrogen peroxide can be broken down further, yielding the hydroxy radical. And all three of these species that I've circled are highly oxidative, and they're going to cause oxidative damage to whatever environment is around them, specifically to DNA and to proteins. So these species are all toxic to the microbes. Now, where does the selectivity come from? Where does the selectivity come from? Yeah, it's only metabolized to these species inside the organism. Inside the organism. Okay? So once the organism dies, our bodies have pretty good ways of dealing with this. Okay? So we have enzymes called superoxide dismutase, for example, which get rid of superoxide. We have catalase, which gets rid of hydrogen peroxide. So we have enzymes that are able to deal with this, these species, if the body is normal. The bugs don't. So they build up in the bugs and they die from it due to the effects mainly on DNA and protein. Importantly, going back again, this drug metronidazole has an antabuse-like effect. You guys remember antabuse, right? Disulfiram. If you drink with it, you get sick, essentially. Okay? Nausea, vomiting will happen, and you get the feeling of being hungover. Okay, so that feeling of being hungover comes from the buildup of acetaldehyde in the body, and this agent essentially inhibits the metabolism of ethanol properly. So if it's taken with ethanol, you start building up acetaldehyde, and acetaldehyde is what causes that feeling of hangover. If any of y'all know what that is. Questions about this? Okay. It is carcinogenic in mice, so it's contraindicated in the first trimester of pregnancy. So those are all the considerations. Okay. For these organisms, by and large, this is going to be the drug that's used. Okay. There are some other drugs that I'm going to talk about here, but they're not going to be used to the same degree, not even close. But to be prudent, we have to discuss these drugs as well. Furamide is only available in the U.S. through the CDC. And this drug is directly amoebicidal, so it's only used for Entamoeba histolytica, often in combination with metronidazole. Okay. CDC and the manufacturer of this drug provide it to the third world. Okay. So it's kind of used for third world purposes. In the U.S., if a patient needs it, it can only come through the CDC. Alinea is an agent that is limited to giardiasis, although it is under phase 3 trials for C. diff. And this drug, again, is only going to cover Giardia lamblia. Okay. And I've shown you here kind of the mechanisms of how these work. This one is directly amoebicidal. We're not going to talk about the mechanism of that in detail. This one here inhibits oxidative phosphorylation in Giardia, so it decreases ATP synthesis. I'm going to leave it at that. These drugs aren't used that frequently to get into very in-depth conversations about their mechanisms. I think it's important to throw the names at you and what they cover just in case you see them. Tinidazole is a fairly new drug, and it's a metronidazole congener, so it looks kind of like metronidazole in structure. The mechanism will be similar to metronidazole. Creation of reactive nitrogen species here as a result of the nitrocleavage by susceptible organisms. Again, it's going to induce DNA damage. And this one you can see is approved for trichomoniasis and bacterial vaginosis in non-pregnant adult women, giardiasis, and amoebiasis. Got it? So that's that. Again, metronidazole 99.9% of the time is what's going to be seen. Resistance isn't a huge problem. You can't get away from reactive oxygen species. They're toxic. There's really nothing the bug can do about it. So resistance isn't a huge problem with this. All right, if there's no questions, let's move on to pneumocystis. Pneumocystis is a very unique organism. It's classed as a fungal protozoa. So it's got fungal features and it's got protozoal features. This is caused by Pneumocystis jirovecii, which was formerly called Pneumocystis carinii. Okay, Pneumocystis carinii, and we talked about this in the name change. So it will be beneficial to you. You'll see this in fourth year for sure. It's very common in the hospital settings with AIDS patients. Okay, and I think Dr. Wong has a poster out over there by the pharmacy practice suite with some of her research and a patient case that describes a patient with Pneumocystis jirovecii. So you will see this next year on rotations. Okay. Most humans will be asymptomatic carriers of this, but it is an opportunistic microbe, and primarily AIDS. 80% of the AIDS patients with it will contract pneumonia, and that's a main cause of death by way of this organism. It does have a 50% recurrence rate in these patients. Okay. It can also take opportunity of immunosuppression. So in immunosuppressed patients, those are on transplant rejection drugs are liable to get this infection. As are premature or malnourished infants, this is mostly going to happen in the third world now. Okay? Our premature and our malnourished babies, infants, are pretty well taken care of in the hospital. If they're in the hospital, they're pretty well taken care of. So this is more a third world bullet point. It's going to exclusively infect the lung lining and the alveoli, causes a severe pneumonia, and that's going to cause hypoxia. And again, lack of oxygen means that the organs will start dying off. This organism was virtually unheard of before AIDS. Virtually unheard of before AIDS, as it doesn't cause, in normal immunocompetent people, it doesn't cause any disease. So how do we treat pneumocystis? There are 4 choices that I've listed here. Sulfamethoxazole trimethoprim has a pretty wide and variable but pretty good response rate. Clindamycin can be used. And so those are 2 drugs that we've covered already. I'm going to skip this one for a minute and come down here and then come back up. Atavacone can be used. This is actually an anti-malarial drug that we'll talk about in a minute. It's going to inhibit oxidative metabolism processes, and in doing so, the fungal parasite can't generate ATP, and it will die. Trimethoxate and folinic acid can be used in combination to treat pneumocystis. Trimethoxate is a dihydrofolate reductase inhibitor. Okay? So it's going to do what inside the Pneumocystis jirovecii organism? What's the end result? No folic acid. The end result is DNA can't be replicated, right? DNA can't be replicated. However, this drug also inhibits mammalian folic acid processes. So that's not good. Okay, it also inhibits mammalian dihydrofolate reductase. So trimethoxate is very effective at killing off the bug, but it's also going to inhibit mammalian dihydrofolate reductase, which is not a good thing. So when it's given to humans, it's given with folinic acid, which is a mammalian folate replenisher. Okay, so folinic acid will replenish the mammalian's cells folic acid, but folinic acid cannot get into the organism, the pneumocystis organism. So it's going to selectively replenish the folic acid in the mammalian cell without replenishing the pneumocystis folic acid. Okay? So you get a DHFR inhibitor and then mammalian folate replenisher in combination. And again, I'm not going to spend a whole lot of time on the mechanisms of these. Leave it at ATP generation. This one's easy enough to understand. You already know how these drugs work. Okay? Any questions? Those are the parasites, the 4 or 5 parasites that are most commonly seen. Any questions before we move on? All right, let's do malaria. Malaria is a big deal. There's 300 million annual infections and 1 million annual deaths due to malaria. Malaria is mainly a disease of the tropics. So you can see in this purple shaded area is where malaria is highly prevalent. And so in the United States, mainly it's travel to these areas and coming back home to the U.S. that patients pick up malaria. The symptoms of malaria include fever, shivering, joint pain. Fever, shivering, joint pain. As well as vomiting. The 2 classical symptoms are anemia and a cyclic fever that occurs every 2 to 3 days. Okay? The classical hallmark symptoms: anemia and a cyclic fever that occurs every 2 to 3 days. And I'm going to talk to you in depth about the malarial life cycle so you can see exactly how that occurs. Malaria is transmitted by the infected Anopheles mosquito, which is shown here, specifically the female mosquito, because the male is only around for a short while to make more females. So the female is the one that's going to transmit this organism from her saliva into the human bloodstream. Okay? The organism that causes it is within the genus Plasmodium, and there's 100 species within Plasmodium, and only 4 of them, the ones shown here, cause human malarias. The biggest one that causes 90% of the infections and 80% of the deaths is Falciparum, Plasmodium falciparum. Vivax malariae and ovale are the other 3, but the falciparum causes the vast majority of infections and the vast majority of death. Okay. Now I've talked about the symptoms. These are the main reasons that people die from malaria: the anemia, pulmonary edema, renal failure, jaundice, shock. So these things are typically what's going to cause death if it goes this far. So let's look at the life cycle of this, and I'm going to spend a little bit more time because this is important, and this is, you got to know this. Remember I told you I'm not spending a whole lot of time on the earlier ones, but this one we're going to delve into. Okay. Essentially what happens is the parasite, the Plasmodium parasite, will be sucked up into the female Anopheles mosquito. Now why the female? Because the female is the one that goes out in search of blood. Okay, the males don't feed off of human blood. Like I said, they don't live much longer after they mate. And so the female will be the one that takes up a blood meal and takes up the organism into her gut wall. And in the gut wall, the oocysts, the eggs of the Plasmodium, will develop. Okay? So the eggs of the Plasmodium are sucked up and develop in the gut wall of the mosquito. After they're in the gut wall, they're going to develop into what's called a sporozoite. And the sporozoites will migrate to the mosquito's saliva, and when she takes her next blood meal, those sporozoites are injected along with the mosquito bite. Okay? So it's essentially, that's how the cycle spreads. So it comes from one person, develops in her belly, and then migrates to her saliva, and then when she takes the next blood meal, the sporozoites are injected when she starts eating. Okay? So that's the mosquito stage. The mosquito stage. I'm going to show you the human stage in more detail on the next slide. But that's the mosquito stage. Only the females. The females generally start feeding at dusk through the night. And so that's why a lot of people in the tropics use the mosquito nets to sleep, because that's when these mosquitoes are active. And so a simple mosquito net that's very cheap can be an effective way to prevent malaria. Unfortunately, getting mosquito nets there is the challenge. There's a lot of people in these areas. Okay. Questions? Pregnant women are especially attractive to the female mosquito for some reason. It's not known why, but pregnant women are almost sniffed out by the mosquito. And so this can be a pregnancy complication if the pregnant woman gets malaria, because she's going to get anemia. Okay? So you guys with this? This is the mosquito life cycle. All right, now let's talk in depth about the human life cycle. So here we are, the mosquitoes come in here and it's taken a bite, and the sporozoites have been injected into the human bloodstream. The sporozoites, within 30 minutes of injection, can infect the hepatocytes within the liver. Okay, so within 30 minutes they infect the hepatocytes in the liver, where they replicate and mature for a period of 6 to 15 days. So within 30 minutes they're going to get to the liver. They like hepatocytes, that's where they replicate and they mature over a period of about 6 to 15 days. Now, after that 6 to 15 day period, these things have matured into what's called a merozoite. So sporozoite develops into a merozoite, which is now a more infectious adult. Okay, so think of the sporozoites as the kids. Now they've grown up and they're able to be more infectious. The merozoites will shed from the liver after that 6 to 15 day period, encased in the hepatocyte cell membranes. So as they leave the liver, just like HIV took the cell membrane as it budded off from the host cell, these things are taking the membranes from the hepatocytes. And in doing so, the organism is encased in mammalian lipids and is able to avoid the immune system as it circulates in the blood. Right? So you got an organism that's lying inside what looks to be human cell membranes. And so the immune system won't note that as being a foreign particle. So these things are free then to circulate in the blood without being detected by the immune system. Okay? Now, the merozoites then go into, so this is known as the liver stage. After the merozoites are escaped, they go into what's called the red blood cell stage. At this point, the merozoites are shed from the liver into the circulation, where there's an abundance of red blood cells. And so essentially what's happening is the merozoites are going to infect those red blood cells. And within the red blood cells, the organism, the Plasmodium organism, uses hemoglobin as its main source of nutrients. hemoglobin will be its main source of nutrients. And it uses its lysosome, so the plasmodium lysosome, to break down human hemoglobin. And what will the result be? Say again? No. So what will the end result for the plasmodium be? It's breaking down hemoglobin. What is it getting out of it? Amino acids. Amino acids, right? Hemoglobin's a protein. It's trying to use our hemoglobin to build its own protein. So this is serving as a nutrient source for the plasmodium. You guys with me? Because I don't write a lot here for you. I gotta say it all. All right, slow me down or stop me if you've lost. In this red blood cell stage, they're using hemoglobin as a nutrient source. They also express a toxin which lyses red blood cells. And depending on the species, so remember there's 4 species of these, right? Depending on the species, this toxin takes about 2 to 3 days to lyse the red blood cell. Depending on the plasmodial species, the toxin that they express takes about 2 to 3 days to lyse these red blood cells. Now, what happens when the red blood cell with these plasmodium busts, lysed? What happens? Robbie? Okay, but before then, what is happening in this point? So the cell is busting. What is happening? All of the plasmodium that's growing in this particular red blood cell is released. Okay, when that red blood cell busts, when it lyses, all of the plasmodium comes out. Okay, how often did I say it takes for the toxin to lyse? About every 2 to 3 days. That means about every 2 to 3 days you're getting release of a huge amount of organism from the red blood cell. Where did I say the hallmark symptom was? Cyclical fever that occurs every 2 to 3 days. So yes, Robbie, you do get an immune response. That immune response is to increase the body temperature in response to the cyclical shedding of these from the red blood cells. So the shedding of merozoites from the red blood cells every 2 to 3 days. You guys with me? Yeah. Yeah, that's assuming that they all infect at the same time and leave at the same time, which is essentially what it is because it's a wave. So you get let's say it takes 6 days to come out of here. So after 6 days, they're pretty much all coming out. And then they all pretty much infect the red blood cells. And then every 2 to 3 days, it's a wave of, it's not all or nothing, but it's the majority at the same time. Yep. Okay. All right. Now, a couple other things. Since pregnant women are particularly attractive to this mosquito, it represents a problem because these merozoites can adhere to the placenta. Okay? They can adhere to the placenta. So they express an adherence protein that can adhere to the placenta. What happens if these red blood cells that are infected are sticking through this adhesion to the placenta? What's going to happen? So you're inside, so this is the placenta. You're inside, essentially, an artery that's supplying blood to this placenta. But what do you see that's going on here? Yeah, it's clogging. Okay? So the blood flow to the placenta is going to be decreased. The blood flow to the placenta is going to be decreased. So this is actually one of the leading causes of stillbirth. And so a pregnant woman that gets malaria is at risk for having a stillbirth delivery due to this adhesion that the organism will cause. Okay. The other thing that can happen is that the infected red blood cell can adhere through this adhesive protein that you see to the endothelium, okay, within the vasculature. So what is this going to cause? Ashley? Clot. Clumping of these red blood cells and clot formation. Clumping of the red blood cells and clot formation. All right, I think we should take a break. We'll come back at the top of the hour.